Yeah.
Yeah, we can. Okay, good. Because I'm gonna do I'm gonna use the board here in a second, so I want you to be able to see the board. Usually it shows my face and I hate it, but I don't like y'all seeing me, but it's okay. I just want you to see the board. That's what I want you to focus on. Okay, so I'm hoping to get through this by 10 because I'm going to give you guys a little time to work in groups and kind of study this stuff because then we're going to play a game. And usually it just gets you all to kind of present me the information. I mean, it's easy. I have buzzers and it makes it fun, but it's interactive, so then you kind of can remember things a little bit better because you have to recall what I already told you during class. So in cellular regulation, this is probably one of my. It used to be I did not like doing this topic. It was hard. I mean, a lot of people probably in this class has had somebody that's had some form of cancer, has passed away. So it's really hard for me to get through this. But then as I, started doing this lecture more and more, it became almost one of my favorites. Even though I still, don't like the topic of cancer, but it's something that a lot of people have to live with. So, we want to learn as much as we can about it. So, cellular regulation. Cells are the smallest form of life. They are functional and structural units of all living things. So when we think of our cells, we have to think that are they living or dead? They're living, right? That's what makes up our body. They do die. They have programmed cell death, but in essence, they're living. Okay. So most of these processes have at least one breakdown in cellular regulation. So we're going to concentrate on cancer, but I really want you all to understand what cellular regulation is. So if we think about alpha cells, beta cells, where are they at? Do you remember in physiology?
Well, Tyler's trying to get it through.
Oh, thank you. I thought Tyler was in here.
The computer died.
Yeah, I didn't hear that part. Okay. So where are the alpha and beta cells? Physiology. What is it?
Pancreas.
Your pancreas. So what do the alpha cells do? When are they alerted? Yes. So when our body is kind of in that going in that hypoglycemic episode, our alpha cells say, "Hey, we need some glucose," and then our body gets the glucose. Beta cells is kind of the opposite. It's in response of hyperglycemic episodes. So that's when like patients with insulin and things like that, they need the insulin, and so they would get diabetes. And our body doesn't do that. So when we talk about cancer, it's kind of similar to this breakdown because if we have cancer cells, then our normal cells cannot act how they should. I'm not going to ever read my objectives to you. Okay, so I could not find cells, to be honest, to show you what they look like, so I have to keep them off, okay? So original tissue is kind of the top one, okay? That's what we call original tissue. So it's, what do you see about it? Compared to the other ones, what do we see? Yeah, it's normal size and a normal amount. Now let's move down to the next one. What do we see? What's the difference? They're bigger. What about how many they are? Is it still the same? Yeah. Okay, so the biggest thing, this would be like a hypertrophy, okay, where our tissue gets bigger, not because there's too many cells, but because they're just bigger. Okay, so this is kind of like V9 condition. Then we move here. Are they bigger?
No.
No. But there's how many? Too many, right? So this is like a hyperplasia. Okay? So with hyperplasia, are people at risk for cancer? Absolutely. So we can think of like endometrial cancer, for instance, or endometrial hyperplasia, I'm sorry. Endometrial hyperplasia, and I use a lot of women's health because I did this for years. So when women come in, they're having this awful bleeding, and so the nurse practitioner, physician, whoever is in there will say, okay, well, let's go in and take a biopsy. So what they do is they take this literally looks like a straw. They kind of open it for the suction, and they slide it up through the cervix, and they just move it around. It makes you cramp, but they move it around because what they're doing is hitting your uterus to get cells. We send that off for pathology. If it shows hyperplasia, what do they want to do? Leave it? What are they going to do? We've already biopsied it. Yeah, they're going to literally go in for like a DNC, something like that, where they take a big ice cream scoop, similar to an ice cream scoop, and they scoop it out. Because what are they trying to do? Eliminate it, so when they grow back, they're hopefully normal. It's similar to like a skin biopsy. Have you ever had a skin biopsy? And if you've ever seen a Mohs treatment, I got to do that in my master's program. I went and watched a dermatologist. I'm from a small town, so like their family practice, their dermatologists, they're all in the same thing. So she's like, oh, my cousin was like, oh, just go watch him for a little bit. So I went and watched this Mohs therapy. So what they do is they take a patient in. My granddad actually did it. He'll remove like the skin, right, or the mole, whatever, and then the physician will actually take it back, the dermatologist, and he looks at it under a microscope. What's he looking for? Yes, he's looking to see now, does he have a clean base at the bottom, because that means he got it all. If not, they go back into the room and they biopsy more. So it's usually an all-day treatment, but they usually have 30 patients in there that they're doing at the same time, so that this person doesn't go kind of like I had to, go get a biopsy, okay, go home, oh, you need to come back in, we need to cut more. You go back in, you have to cut more. But the Mohs therapy is really, really neat because they do it all in one day.
So how do you know if you got enough? I mean, what's a clean base?
Well, that's what they look at under the microscope. They look at how the cells are, the abnormal cells, and if they still see that abnormal cell on the edge, then they cut more to see that clean. So then when they grow back, they're hoping that they grow back normal and not abnormal. Because we're going to talk about that and why it's so important in a second. So what do cells do? Why do we need to regenerate cells? Yeah, so we have to replace them. And that is how all this kind of starts and begins. Is everybody at risk for cancer? Yes, we're all at risk. And as we age, it gets worse. And we can't change age, but there are a lot of things we can do to eliminate carcinogens within our body and things like that. But with hyperplasia, it just means that our tissue is getting bigger. It doesn't mean it's bigger in size, but what happens is there's so many cells when they clump together, that's what makes those tumors, and that's what makes them grow, is it's too many cells. Do you guys kind of see that picture? Okay. This is kind of pathophys. I do not go into too much detail because this, again, is just kind of going back through your physiology. Am I going to ask you about those cells and things like that? No, I'm not. I'm just trying to get you, to where you're like, oh, okay, I get it now. So with cellular regulations, we have mitosis. Do y'all remember that? Have you had biology yet where, the cell divisions, all that fun stuff? And then we have the proliferation and then the differentiation. Differentiation is just all these cells have specific tasks. So our white cells, our red cells, our beta cells, our alpha cells, our liver cells, all these things they have specific cell functions. Neoplasia, these cause the neoplasms, which are either what? There's two types. A benign condition and a what? A malignant. So it's simple as that. Do we want a benign condition? Yes. We'd much rather have it see a benign than a malignant. In our bodies, we have our surveillance system, kind of like our immune system, should be able to recognize errors with mutations. So all of these different abnormalities in cells should be recognized by our body. That's why some people are able to kind of eliminate cancer risk, just because our body recognizes it and says, hey, there's an error, and it kind of flags it, and our bodies can get rid of it. But what happens sometimes is our bodies can miss it. So then, with this abnormal cell cycle, it goes unrecognized, and then we have malignancy that happens. Actually, did something fun for you guys. I used to only put normal, and then this is important, not for you to understand for a test, but to understand why you see stuff in cancers. So a specific morphology is what we want to see. So a normal cell, a pretty normal circle, okay, with a little nucleus, how it should be, okay? So it has a small nucleus of cytoplasmic ratio. Okay, so normal. This is what they want to see on a microscope when they're looking at that. Can you guys see the board? Because I can't see what you see.
Oh, we can see it.
Okay. Cancerous, they have an indistinct, right? Like they're smaller. Okay, so when they see these cells, they're going to see kind of a smaller cell. So then the nucleus stays the same size. So that's why it has kind of a larger nuclear to cytoplasmic ratio. That's how they can tell like what's a cancer cell as opposed or an abnormal cell compared to a normal cell. Differentiated functions, obviously it contributes to the body. Our normal cells do. Cancerous cells, there's no useful purpose. They just want to destroy our body. Tight adherence means that they are tightly bonded together, which also means with the contact inhibition, their division stops when they butt up against each other. This happens in a normal cell. Cancer cells, they don't do that. Cancer cells have loose adherence, meaning that is even with their contact inhibition, it doesn't occur. So when they butt up against, say we have liver cancer, okay, cancer in our liver, and it grows, a tumor grows, and it hits our lung. Do you think it's just going to stop growing because it hit our lung? No, it takes over. It doesn't care. It's like, screw you, I'm going to take over your lung too. So it takes over a lung. What loose adherence is this is what we always say is a no-no. Like, if somebody has cancer, do we tell them if they have, like, cancer on their arm or something to just dig at it? No. We don't want to break it up, right? And that's like the same thing. If they have a tumor inside their stomach, inside, we don't want to be palpating or hitting on it because what happens if we're pushing on it? Can it break off? And then guess what? Then it's like, have you ever, this may sound morbid. When I was little, I didn't like spiders. I still don't like spiders. But the sacks, I had never done this until I was little. I was like, oh, there's a huge spider. And it was, my parents had these big wood spiders. And I know they're not poisonous now, but I didn't at the time. And she had a sack on her back. And I stepped on her. What happened to the sack? So that's what the cancer does. It just spreads like those little spiders. And I'm like, oh crap, I was trying to kill one and there's 500. So try to think of something like that it just spreads and that they bleed. Oh my goodness, they bleed. The best way I can explain this to you is the first time I really understood that process is when I was doing a pap smear. Okay, pap smears, women, you know what we're talking about. So a normal pap smear, you go in, you have like this spatula, you scrape the cervix, right? Doesn't really hurt. It's uncomfortable, but you know, it is what it is. They scrape the cervix. Sometimes you may have a little spotting just because if you have like a little inflammatory process going on, you can bleed a little bit. But it's not common that you really should bleed. We need to figure out why you're bleeding. When somebody has cancer, this happened one time in my entire career doing this. When you go to scrape, it literally slops off. Like the entire like cervix starts to just, and you're like, oh shoot. And so you can't really tell until you touch it, but as soon as you do, it just falls. And you kind of know at that point, this isn't going to be good. So now you know when you're hitting on cancer or touching or palpating or whatever, it can break apart very easily. And plus, they have their own blood supply. Does cancers migrate? Yeah, they migrate through your bloodstream. Again, butting up against another organ, they can take over. Apoptosis programs cell death. So normal cells, they're programmed to die. Cancer cells do not. Almost like immortal. Again, here we have your neoplasm, so your benign and malignant. So again, what happens with benign cells is they grow at the wrong place, okay? They can be normal cells, but they're just completely at the wrong place. So what are some examples of benign tumors? Fibroids. Polyps may be benign. Again, we have to biopsy them to see if they're benign. And again, any of these tumors that we may see, they usually biopsy. So women with ovarian cysts, things like that, if it's a tumor, they'll do some tumor markers to see if it could be cancer, and if they're not, and they're like, okay, it's probably benign, but we'll take it out and see.
My 8-year-old, we had to take him to Cincinnati when it was less than a year old. I can't remember exactly how old he was. He had a myofibroma on his tongue.
On his tongue?
Yeah, but it was benign what he did.
Was it big?
It the longer it went on, like when he was first born in the NICU, it was really you could notice it on it was on the side of his tongue.
Yeah.
And then like the older he got, it kept getting bigger.
And
It
probably
was
like
good
causing him
size.
to be able to eat.
It did.
Yeah.
Well, he kind of did it off to the side, and then when they took it off, he kind of had to learn to suck a bottle again.
Yeah. So even things like that, we don't know why these benign cells occur, but they do. And it's even like if you think of endometriosis, women that have that, endometrial cells, why women have so much pain, like women will complain of pain going down their legs. And you're like, why does that happen? Endometrial cells grow outside the body, in the stomach, on the leg, everything. So every month when they shed, what's those endometrial cells do? They don't know I'm not in the uterus. They just know I have to shed at this time. So that's why they get so much pain throughout their bodies.
You said they grow outside the body, but you meant outside.
In the outside of the uterus. Yeah, outside of the uterus. I should have said yes, outside of the uterus. So your term, primary versus secondary. What is a primary cancer? Do you know the difference, primary versus secondary?
Primary is where it started. Metastatic is where it's moved to.
Yes. So how do they tell if I have breast cancer, okay, or lung cancer, or vice versa, whatever, and now they see, like they do a PET scan, and now they see another area light up on the lung. And so what do they have to tell? How do they determine if it's a primary lung cancer or if it's just secondary?
Because if it's a breast cancer cell, it's in the wrong place.
Correct. So that is how they see the difference. And so when somebody says, I have a lung cancer, but it started in my breast, you know what they mean. That is that breast cancer. So some patients will say that. My granddad, he had kidney cancer. And then they said he didn't do any chemo, nothing. They said they removed it all. Years later, it actually metastasized, and they never knew it to his lungs. So his lung cancer was what actually took him. But so those are the things that how you can tell. But he'd always say, I have like my kidney and my lung, and we're like, oh gosh. So you may hear stuff like that because they, just how they say it. Carcinoma, sarcomas, blastomas. When you hear different cancers, I'm not going to ask you this, okay? I'm not going to say cervical, is it carcinoma, sarcoma, blastoma? You don't need to know that stuff. Just when you're working, you'll understand what cells are being affected by if it's carcinoma, sarcoma, blastoma. Okay. Also, when you think of cancer cells, if they grow on vital organs, do they kind of sometimes have a poor prognosis? Yeah, because it's a vital organ, okay? So it can cause a lot of complications. Solid tumors, so again, we may think of breast, lung, cancers, hematologic, we'll talk about leukemias, lymphomas, multiple myelomas here in a second. And a good thing to really, and I had to do this, so I already have the 9th edition, so I had to go into your 10th edition and update it, but you want to know this table. You really want to know common sites of metastasis just because it's important, and it's easy to really memorize because it's basically saying, like, if somebody has a kidney cancer, where could it possibly metastasize to? So you think, like, what are those sites that are close to it? Really, you have to think of bone almost with almost any of them, just because bone is around. Yeah, it protects our body, so our bones are pretty prevalent in being secondary cancers. You want to hear something mean I used to do to students? I didn't mean to. It's just something my instructors used to do, so I thought that's what we were supposed to do. I used to say all the information for these things. But guess what I did for y'all? Yeah, my first time teaching, everybody hated me. And I'm like, so that's what they did to me? I think it's nice. Testicular cancer. Okay, let me reverse this a little bit. With cancers, we know that people they're more at risk as they what? I said it,
Age.
as they age. What do we notice about testicular cancer?
Relatively young.
They're young. So it's really important for men, young boys especially, when we're educating them, to really check their testicles. Best place to do it is in the shower. Why?
He calls them the
Yes. Okay, so everybody knows my son now. But when he gets mad, and pediatricians, you don't like them, but when they scream, what do? Whoop, they go up in. And they're like, just make sure. And I'm like, so in the bathtub, they're like, yeah, just fill all around. I'm like, oh my gosh, he already does that. So, yeah. I'm like, we know all about that now. So they notice a painless lump or swelling. Okay, so that's why it's important to be, checking around. It's not weird. Just do it. Women have to do it with their breasts. Same thing for their testicles. So these are some of the things that we notice with testicular cancer. It's important just to kind of know what side effects, right? What we kind of see signs and symptoms for these patients. High risk, HIV, HPV. We are seeing HPV really affect more men. And did you guys know that now the Gardasil is given to young boys? I mean, I think that's great. So, cryptorchidism, do you know what that is?
Hidden testes.
Yes, undistended testes. So that's why it's so important for pediatricians to be checking our young children because they want to make sure that they're not undistended and because it can cause testicular cancer. Back pain is also a symptom that men have. Cervical cancer. So I talked a little bit about cervical cancer. So a big thing that a lot of women notice, I didn't really see a lot of abnormal discharge with my women that had cervical cancer. What I did see was the painless bleeding, just constant bleeding. They have sex. Why do I bleed all the time? Well, I would always know, like, okay, well, even if they had maybe chlamydia or something, it was an inflammatory process, right? So cervical cancer is the same thing. So when they're having sex, they're hitting their cervix, so which causes them to bleed. HPV, which two HPVs cause cancer? Cervical cancer specifically? Which one? Two. Remember? 16 and 18. 16 and 18 are cervical cancers, and that's why we give Gardasil. CAP screening begins at 21. Should it begin earlier if they're sexually active?
Yes.
0. No. I had moms bring their daughters all the time, 15, 16. Oh my gosh, have sex. Like, well, we don't do screening until 21, but they have sex. Doesn't matter, not until 21. This guideline I'm okay with. Guidelines as far as waiting 5 years, don't ever wait 5 years. Even if your practitioner says, well, you're HPV negative and you're fine. I had a close family member who was in her 30s, young 30s, and she has lost everything because she kept telling them she had spotting and they kept blaming it on her birth control. Finally, when she was due for her pap smear 2 years later, her cancer has spread. So don't do that. Tell them I'll get somewhere else that will do it. Okay? Because you just do not want to wait that long. Practice safe sex. So what things can we educate on? Condom use, abstinence. We can tell people till we're blue in the face, the best way to do this is don't have sex for young people, but they're going to do it anyway. So best way to do it is teach them and educate them on protecting their body. Breast cancer. I want to say this, and anybody that knows this, don't say it. Well, yeah, you can't say it, I guess. Early menses, late menopause, malparity, later in life pregnancy. Why? Why do these affect women and can cause breast cancer? Early menses, late menopause. What do they all have in common?
They bleed more. Have more periods. Am I in there?
I think you're on the right track. Okay, so what happens with our body? Do we have estrogen? Okay, so during pregnancy, what's our estrogen levels now? So we get a break from estrogen when we're pregnant. So I always say Miss Duggar, that has 20 kids, really good. Because she has had a lot of breaks with her estrogen levels. Later in life pregnancy, it's the same thing because they went that long time, that long period without ever having a baby. So then if they didn't have that break in estrogen.
That's why they say if you nurse, that it's less because you don't have it.
Yep, because you reduce those hormone levels. Family history, We screen for BRCA1 and 2. Does BRCA1 and 2 say that you're going to get cancer? You're going to have cancer? No. It just means you're very, very high risk, okay? So a lot of women who I've had family that had, on my mom's side, they have a lot of her sisters and their daughters all have breast cancer. So a lot of them, if they're screened and they're positive, what do they probably go ahead and do? They go ahead and have mastectomies. If you have a mastectomy, because I know this has been test questions previously, not on my test, but other tests, okay, I've heard, students told me. So with mastectomies, do you still have to go in and get breast examinations? Yes. If you've had breast cancer and you have a mastectomy, why is that important?
Because the cells could still be present.
Where do they usually tend to go?
Lymph nodes,
Where else?
some,
When they cut the incision line. I don't know why.
on the scar, around the scar tissue.
Yes. So you have to really check around that scarring, because that's where usually cancer cells will migrate to. History of radiation, that kind of increases anybody's risk for any type of cancer. Postmenopausal hormonal therapy. Again, we have to be very cautious with women that want this. I know that menopause probably is not fun, but we really have to be cautious with the therapy. Alcohol smoking, you'll see these risks with even gastric cancer, things like that. But smoking increases your risk for almost all cancers along with age. Things that we may notice, signs, discoloration. A lot of times women may have like this orange hue to their breast when they have cancer. They may have a mass that we feel. One thing they may notice is they'll say, bless you, nipple inversion. So maybe their nipple doesn't erect like it used to, and they think, well, maybe it's just my age. But what we notice and what they have noticed with cancers is when there's a cancer beneath the nipple, what it does is it pulls it back. So it kind of retracts it. And that's why they have nipple inversion. Vein engorgement to the side that's affected. So you may notice like there's like the veins to that one side are just really engorged, and it's because of that blood supply going to the cancer. Scaly areas. Well, this is kind of with any dermatologic cancer, you notice kind of those scaly areas. So if you see that, even on yourself, you need to go. Even if it's not your breast, it's on your body, you need to go. Monthly self-breast examinations. Do you now know they don't educate on that anymore? They say that we should not educate women about the breast. Dumb. I don't agree with that. I've had men that have found their wives' breast cancer. I mean, they feel it, so.
What's their reasoning behind
I don't know. I guess they think that they don't know how to adequately do it. So because say you're on your period, should you check your breast when you're on your period? Women, no, don't do it. Because your breasts are very hormonal, and at that time of month, wait till a week after. At exactly a week after, you can check those. And educate those patients on that, because sometimes if they're lumpy during their period, they think, oh my goodness, I'm lump, and they go in and false alarm. I guess that's why, but I'm like, I'd rather be safe than sorry. I've had women in their 20s having breast cancer. Like the last time I worked, I had 2 women come to me, and they both had breast cancer. Clinical breast examinations begin right around the same time your pap smear does. Yearly, you need to do those. Mammogram, we are now seeing mammograms wanting to be pushed further away. So instead of 50s, they almost want to do them at 60s now. Smart or not smart?
Not smart. Well, now they're pushing them every 2 years instead of every year.
Yeah. So unless you have like this high risk or they've noticed something, they may do it. And then you have some physicians that are like, I'm not doing that. I want to be proactive. So definitely find somebody. I feel like, you always want to evolve with evidence based, but some of the stuff I don't know why they're doing it. I don't agree with it. Maybe I'm just not into it as much as I used to be, but I just don't agree with it. Let's see. I've already said that. Okay. So your gastric cancers, stomach cancers. You guys are going to hate me if you like some of this. Okay. So it begins in the glands of the mucosa. Risk for eating pickled foods, nitrates. Anybody like to char your hot dog, make it real dark? Anybody? Don't do it. Bad. It's really bad. I didn't know that either. My dad loves those. I don't, but my dad does, so I had to educate him on not doing that. It's actually a cancer risk. Appetite changes. We may notice patients saying they're just not as hungry as they used to. They have indigestion. They feel full. They have nausea, vomiting. So that's when sometimes they'll do a scan and see if they notice any type of tumor. If they have to remove part of the stomach, they're at risk for dumping syndrome. Not really anything I really test you on just because that's, whole, just the signs and symptoms and things like that. We want to educate on smoking cessation. What does smoking do to our stomach? Can it irritate it? Along with alcohol. I had a patient in home health one time. She kept getting, she didn't have cancer, but she kept having stomach ulcers, like she's bleeding on like stomach bleeding, everything. I mean, she just really had a lot of issues. So when I went to see her, the first time was fine, everything was good. The second time she happened to be, she was probably in her 80s, and she was babysitting her young grandson. He was probably 3. He's going up and down steps, and I was like, oh my goodness. She had already had her wine filled up. It's 9 a.m. and she was smoking, and she was falling asleep when I was on my assessment, and she was the only one home with her child. So I called the physician's office because I said, hey, I think I may know why she keeps going to the hospital for all this stuff. So she's been drinking, and I'm here at 9, and she's already had a couple of glasses. I said, she's falling asleep on me. I said, she's smoking. And I kept having to wake her up because her cigarette was falling on the couch. I'm like, oh my, she's going to burn her house down. So, calls had to be made, obviously, because it was a safety issue. But this is huge when you see something like that, because then it makes you start thinking, okay, well, this definitely could be the cause of what's causing, bleeding, but then she's more at risk for cancer, right? Pancreatic, it's a poor prognosis, okay? They usually find this later in late stages because there's really no signs and symptoms early on, or maybe they don't really notice them, like the clay stool. Jaundice doesn't really occur until late on. And then like ascites and things like that. So ascites like swelling in your abdomen. Definitely risk factors are diabetes and obesity. Colon cancer. What do we look for with colon cancer? What do we do? When they're over 50, what are some things in the clinics they may do? Colonoscopy, what else? The yearly one. They still do them. Fecal blood test. Yep. So those are things that we can try to rule out to see. A lot of patients, they still mail their stuff in, still just bring it in. But usually they'll have the card. It used to be that, I remember when they used to just bring it in a bag. And we would do them, but now we just give them a card when they do them. Crohn's and UC. What I want you all to think is things that causes inflammation. Okay, so if it's causing inflammation to your colon, what's it doing? Is it irritating it? So if it's irritating those cells, they have to keep regenerating, right? And like I said, if they are having to regenerate and they're overworked and overtired, then they're going on and on and on, so they're more at risk for those cell mutations, which now they're at a huge cancer risk. So that's why these patients that suffer from Crohn's and UC are at more increased risk. Even irritable bowel syndrome, where they may have diarrhea over and over and over and over and over, that causes the same things. If the patient may have to get a colostomy, it's a whole other topic we're not worried about today. And then aspirin for prevention. Did you all know that? That some patients that are at increased risk for colon cancer, their physicians may say, take some aspirin because it can reduce your risk. So if you ever hear that, it's pretty normal. Lung cancer, what are some things that we see with lung cancer? Shortness of breath. Think of the breathing. One of the most prominent things we see is the shortness of breath. Arm pain because of where it is. Again, hoarseness, so if they notice, or like that dry cough or irritated cough, they constantly do that, so then they're like, something's wrong with me. Again, you always have to think in the medical field. Of course, it's not zebras. You don't want to just jump to cancer all the time. But, obviously, if the patient's not getting any better, then they need to look a little bit further and assess. Clubbing fingernails, why? Do you remember that probably from first semester, the clubbing fingernails? So again, without oxygen and poor oxygen. Monitor the respirations, their cardiac, any chest drainage if they have to have the chest tube. And I'm not going to go through all the different types because there's a lot of, like, even in breast cancer, have y'all ever heard of all the different breast cancers? We're not getting into all of that because that's a whole, and we could spend a month talking about cancers. Laryngeal. So again, somebody may be hoarse, things that can cause this, alcohol, GERD, blah, what to do. What are those things doing to our irritating? So write irritation down because anything that can be an irritant can cause the cancers into those areas. Laryngeolectomies. A lot of patients that have laryngeolectomies can, they may have to have some humidified oxygen to begin with, but they can live a pretty normal life. They may not even really need oxygen to the area once they get used to the dryer. Prostate cancer. What do we know about prostate cancer? It's way in advanced stage. Okay, I'm talking like 80s. And what's really nice about prostate cancer, and this is the only cancer I'm going to say is nice, is it's slow growing, very, very slow growing. So that's just something to kind of keep in mind. What they may notice is pain, hesitancy in their urine stream, a change in the urine stream. Vasectomies actually increase the risk. It can maybe cause erectile dysfunction as well. Bone cancer, the most common type is osteochondroma. Maybe primary, but most of the time we see it as secondary because I said your bones are everywhere, so we're going to see that secondary cancer. Any cancer in the brain, you want to think of things that may be altered with the brain because our brain, we need our brain, right? So it depends on where the tumor is. So if it's kind of in our frontal lobe, we may think of those personality changes. We may see, maybe they're really good at math and now they're not. So we see those left and right side of the brain, the hemispheres. If they have those tumors, then we're going to see wherever it is, it's going to be altered. I'm not going to go into too much detail with this. Just know that it can affect any of this stuff. Loss of balance, things like that, because that's what our brain controls almost everything, right? Our liver cancer. So you guys will probably hear a little bit more with Ms. Hackney next week about the liver, but just know that when you guys are talking about your hepatitis, those can cause liver cancer because they do what? They're what to the liver? Inflammatory process, right? So these are some of the signs and symptoms we see with liver cancer. Prevention, obviously reducing alcohol intake, healthy weight, vaccinations, IV drug use, anybody that does, goes and gets tattoos or piercings, things like that, making sure that it's a clean shop. Bladder, pain, blood, cloudy urine, increased frequency. If anybody's had bladder infections, you know what to look at. So bladder cancer can kind of mimic what we feel like when we have back-to-back urinary infections. Back-to-back urinary infections, chronic infections causes bladder cancer because it does what to your bladder? It irritates it. So you see how much I've been saying irritated? That's the best way to, when you're studying this stuff, is being able to look. The signs and symptoms are probably things that you've learned about the cancer, or not cancer, your different organs and what happens, about jaundice. You put jaundice and liver together, right? Things like that. So just when you're studying, that's my best way of studying these things. Another thing with stomach, colon cancer, things like that, foods. What do they always say to avoid eating or watching your consumption? Processed, what else? What about red meat? Because that's everybody's go-to, I feel like, is red meat. Most people go-to is red. And maybe I think that because I grew up on an Angus farm. So what did my parents primarily eat? So that is one thing you really have to educate patients about is really watching their red meats. Look up different red meats because some people on the test, when I say certain things, they're like, I didn't know it was a red meat. But understand what your red meats are. Prevention of cancer as well. What other foods can you think of that would be good to eat?
They always say fruits and vegetables.
Fruits and vegetables. Now, if you have cancer.
But you're looking at, it depends, did you grow them yourself? There's
Right.
not a lot of
Right. You wanna.
Spray, a lot of stuff on
Yes,
them.
you got to be very cautious where you get them. Like those fresh farmers markets are really good for that. Walmart, things like that. Got to be careful of those things. But really looking at what you can do to help yourself. Fiber is really good because have you ever heard somebody say if you get constipated a lot or you sit on the toilet a lot for a very long time, that increases your risk for colon cancer? Have you ever heard that? So that's why they say increase your fiber because it helps you just go, not have to sit there and delay it. Some of these are common cancers in children. Nephroblastoma, Wilms tumor, you may hear that. This is pretty common in children. Usually peaks at the age of 3. If a patient, a child, has, or we think that they could have a mass on their kidney, what's the best way to assess it? If we know that they have a tumor, okay, we already know that they have a tumor, okay, on their kidney. How do we keep track of that as a nurse? How do we know if they're gaining weight or, do we need to push on it and measure it and kind of blah? Why don't we push on it? Yeah. They could hemorrhage, less than that. But the best way to do it is they measure abdominal girth. So they take measure, they measure to see if they're swelling or anything. Neuroblastomas, most common site is the adrenal gland. There can be other sites. What you need to know as far as signs and symptoms of, obviously if it's in the brain or anything like that, like glioblastoma and things like that, you're going to do neuro exams. If it's on the spinal cord kind of further down, then what are the signs and symptoms that we're going to be looking at is going to be where it's kind of affected. So they may have intolerance or those kinds of things. So that's what you need to think of. Osteosarcoma, most common bone cancer in children. These children are at risk for extreme injury. And we'll talk a little bit about what happens with bone cancer. A lot of times when our bone is being destructed, it releases calcium. So that's why they are at an increased risk for injury. Some of these children have to have resections done, limbs removed, depending on the bone cancer. Retinoblastoma is a cancer of the retina. Some children have only one eye affected, some have both. What they see is when they shine. So if you ever go to the pediatrician, they're always checking their eyes and looking at them. Also, what they're looking for is if they see like a white light in their pupil when they're checking it, that's a sign. Redness, swelling. The eyes may look in different directions. Chemoradiation and surgery is what they typically do. I had a patient that never really seen a lot of eye cancers, but I had a patient that she had an eye cancer, and she said every so often they'll come back. They'll say, "Oh, we got it all," but she said what they've noticed with her eye cancer is eye cancers tend to come back. So she says, "I'm just always more aware and knowing that I just need to recognize the signs." This is a lot. So, do you want to hear about this before or after your break? Do you want to do it right now, or do you want to wait and do it after this? You want to keep chatting?
Keep going.
All right. Okay. You may.
I'll go back to this.
I think I do think maybe get through this and take a break because your brain's going to be over something. Can you guys see my whiteboard again? Hopefully. All right, so what I want to explain first, before we even get into this, is the different pathways, okay, that you probably remember from physiology, but I want to hit it again so that you're in that mindset. Okay, so you have different stem cells, right, that make different, your blood cells and things like that. So you have your Oh, that was me. Lymphoid in your I thought these were a lot bigger. What? So you have your lymphoid pathway, and then I'll go over there in a second into your myeloid pathway. What is it? What is it? Lymphoid. No. I thought it was OI. Oh, it is OI. Oh my gosh. Wait, that's what I'm teaching my daughter in spelling. Lymphoid. Okay, so your lymphocytes, okay, is what the lymphoid pathway makes, right? So you have your B, your T cell, and your natural, that's an N, I apologize, natural killer cell. Your B cell matures to a plasma cell, okay? So, you got those? Your myeloid has your granulocytes. It has your erythrocytes, and then your mega granulocytes, you have your neutrophil. You don't need to know this for the test. I'm just trying to, so that when you're studying, you know, like it helps you to study, okay? There you go. Basophil. Oh my gosh. Yeah, take a picture. Thank you. Basophils and your mast cells. Okay. When y'all have that copy down front. For you that are on here, I promise somebody's going to take a picture and send it to you. I'm sorry, my handwriting's awful. I'm sorry. Neutrophil, eosinophils, basophils, mast. That's your granulocytes, your white cells. They're erythrocytes and then your megakaryocytes. I think everybody knows that. Okay, so what we know, what do you see the difference between the two? What difference do you see? Like with the cells?
White blood cells? White blood?
Yeah. Which one, so one of them, right, they focus on what cells? Granulocyte or lymphocytes are what? Your white cells. So these are white cells, right? Over here, you have what type of cells? What type of cells are myeloid cells? What is it?
Red blood.
They have red blood cells, they have your platelets, and they have a different set of white cells. So they have kind of more to work with myeloid. Okay? So when we're talking about leukemias, I don't know if you've ever looked in your book or if you kind of hear about a lot of different leukemias. Do you know how many leukemias are out there? A ton. Okay? And it isn't just the A, M, L, A, L, L, C, M, L, C, L, L. Okay? Okay, let me explain this first. So your first letter, acute versus chronic. Acute is more aggressive, chronic is slower growth. Okay? So these are kind of easier kind of work with if you're more aggressive. Okay? Your M, your L's, what's that stand for? Telling you which side. What are we working with here? And then leukemia. Okay? What's really hard is these all kind of have like a different subtypes to it. A lot of different subtypes in this. And because oh my gosh, like acute lymphoid leukemia, this is the one that can kind of affect T cells, may affect T cells, but it's primarily affecting your lymphocytes. When we come over here to the myeloid, I mean, it could be affecting your granulocytes, it could be affecting your erythrocytes, or it could be affecting your platelets over here. So that's why they have to determine what it is. Am I going to ask you guys to do that? Absolutely not. What I want you to do is focus on when you're studying, because you have to know the different pathways to know what it even talk about. Like, why does this even matter? This occurs in the bone marrow. It can spread, yes, but it happens and it occurs and it comes up and it occurs in the bone marrow. That's where it happens. So why do we see fever, chills, fatigue, bruising, infections? If a white count, okay, if they go do blood work because this person's constantly sick, they don't know why, we're going to do blood work, and they see a white count because the white cells, either the myeloid or the lymphocytes, are affected, and we see a white blood count of 100,000. Is that abnormal? 100,000. What's normal? 5 to 10. Okay, 5 to 10 is normal. White count of 100,000, they can almost always guarantee it's leukemia because the white cells are saying this is way too high. It's not just now an infection, like it's more than an infection. So what they do now, if the myeloid pathway is affected, and it's not the granulocytes and it's the other ones, it may be a little bit more difficult to determine leukemia, but they will find it eventually when they take their sample and they look at all the cells. They'll see what is affected. But why is there still fever, chills, fatigue, bruising?
Because your immune system isn't.
Right. And the reason why the immune system cannot function is because we have all these daggone abnormal cells overcrowding the bone marrow. So now our normal cells have no room. That's why our normal cells are very, very low because the bone marrow is overcrowded with abnormal cells. So that's why we see all these signs and symptoms that we see in leukemia. Kind of understand that a little bit? So you'll be able to see, okay, well, they have infection, they have bruising. Oh, why do they have bruising? What causes bruising?
Blood under the skin.
So your platelets are probably low, right? So bone pain, why do we see bone pain? Where is it occurring? Bone marrow. So, and we may have bone destruction occurring too. So some rest, smoker, treatment of chemo, so all these things can cause leukemia. Moving down to lymphoma. Now this can get tricky because lymphoma can set in the lymph nodes most of the time, but it can also kind of occur in the bone marrow. So how do you tell if the lymphocytes are affected with lymphoma that it's not leukemia? You know that? So usually what they do, they take a sample. They say if 20% or more of the lymphocytes are affected, they say it's leukemia. That 20% of the bone marrow is made of those cancerous lymphocytes, then it's leukemia. I'm not going to ask you to differentiate between the two of them because that. I mean, it's way over. But it's just nice to know because sometimes people always ask me, well, how do they know the difference? And it's honestly kind of like a process of elimination.
So, I mean, I'm just curious, they said they came up with a percent. I mean, obviously they decided on 20%, but I know this is a crazy question, but do you know what geared them or led them to that?
I would say probably just seeing it over and over and over, like kind of like an average. Okay, this is what we see, so this is what we're going to put. Yeah, and I'd say there's probably still research out there because obviously we don't know everything about cancer, but at least they kind of are coming up with something that can help us. So with lymphoma, again, we may see those enlarged nodes, and it may be in a certain area to may kind of follow that lymph pathway. Hodgkin's versus non-Hodgkin's, how do we tell the difference? This cell right here. This is only seen in Hodgkin's lymphoma. So when they take that, they biopsy, and they look at these cells, if that has a Reed-Sternberg cell, and how they see this is they say it looks like owl eyes. They say that when they look at it, it has two nucleuses, or nuclei. So when they, so they say it looks like an owl eye. And you can look at it online, and it's pretty neat to see. It does look like an owl. Risk are Epstein-Barr virus, H. pylori. Things that we may see with these patients is kind of more fevers. They may have weight loss. Leukemia also has weight loss. Lymphoma also, they say, has night sweats, but what they think causes the night sweats, they can't really pinpoint it, but what they have said in research, because I read it with a lot of research and kind of keep my PowerPoints updated, is they say that they think night sweats occur because the body's trying to fight it off, and it causes them to sweat at night. Moving down to multiple myeloma. What do you see here that you see on the board that can also tell you a little bit about multiple myeloma? What's it affect? The plasma cell. So what is the plasma cell? A mature B cell. So plasma cells make antibodies for our body.
When you were over here earlier, you said erythrocytes were red, and then you said megakaryocytes were plasma.
Platelets.
Platelets.
Yeah. Yeah. So your plasma cells now overgrow. They overtake our bone marrow, and we kind of see the same similar. That's why I don't break too much here, because we see the similar signs that we see with leukemia. Okay. Because now our normal platelets, our red cells, all that stuff can't grow in the bone marrow because it's overinvaded by abnormal plasma cells.
They see a lot of multiple myeloma in people that have worked with oil products, gasoline.
So different, maybe a certain type of carcinogen.
Yeah, like mechanics.
Mm-hmm.
A lot of mechanics are getting work, and I recommend anyone that does a lot of crafts. Let's say you do woodworking, stains.
Mm-hmm.
A lot of people who have done that over their lifetime have built up, and a lot of them are getting more.
And probably inside, that doesn't help. So that's something to kind of understand about multiple myeloma is that what cell it affects, because sometimes it's kind of hard to differentiate between the three. But now you can kind of see with where they're all coming from. And we'll talk a little bit more when we talk about immunity about all the specific cells, and not for test purposes, but just for pathophysiology review. So with multiple myeloma also causes bone destruction. So with bone destruction, again, it releases that calcium in our blood, so that's why we see hypercalcemia. And then we also have elevated levels of uric acid because the proteins, there's a huge intake of or level of proteins in our bone marrow, and then it also affects our kidneys, and then that's why we see the high level of uric acid with these patients. Things that we can do with multiple myeloma as far as treatment, they may do the bisphosphonate. glutamate, because it helps the intake of that calcium back into the bone.
They're going stem cells too.
Yeah, oh yeah. And we'll talk a little bit. I don't go into too much detail. Actually, the ninth edition book didn't have anything on stem cells and bone marrow transplants or anything like that. But in the Ural's 10th edition, holy cow, it has like an amazing overview. So what I will tell you, I will not test on that because we do have 2 different books in this class, 9th and 10th edition. So I won't, or I will not test you on that portion on the test, but I will tell you before HESI, star that, write review for HESI, read that in your all's book, because I do know that I've heard that's been on the test. So I can't put it on the test because I don't want to, where some people have that and some people don't. I don't, I'm not going to.
Can you give us a copy of that?
What is it?
The ones who have the 9th edition, study for the HESI? Like a copy of what's in that book?
Oh yeah, I can probably make it. Yeah. Sure can. Just remind me.
Okay.
But it's a really good. I mean, it's like 2 pages long. I looked at it last time. I'm like, man, my edition doesn't have any of that, so it's really nice. Take a break because I know that's over.